Patients here.
Oh boy, got some blood going.
Yeah, this is never blood.
Oh, he's wearing it too.
Welcome to the bed. When you get over to the bed, we'll go ahead and give you the story. This is all going to happen super fast. Welcome to the emergency room.
70-year-old female, single driver vehicle, appears that she went off-road into a ditch, rolled over, her car into a tree, caved in, the top of the vehicle was caved in, and she was hanging out partially from the window. She's been in application
for 45 minutes of CPR. We can stop CPR with 600.
When you break your arm, the X-ray shows this clean, jagged white line.
Right.
And the doctor points to the film, looks at you, and says, there it is. There is the problem.
It's very binary.
Exactly, yeah. It's a visual binary comfort. It's broken or it's not broken. It's basically engineering.
Yeah, we really like medicine to be visible, categorized, and neatly contained.
We do. But the moment you step onto a psychiatric unit or walk into an emergency department room with a patient experiencing a behavioral escalation.
The whole game changes.
Yeah, that X-ray machine is just entirely useless. You are instantly dropped into this diagnostic and, behavioral landscape that is just incredibly murky.
Oh, absolutely.
You aren't looking for a fractured bone anymore. You are navigating neurodevelopment, severe trauma, altered neurochemistry, and sometimes
the imminent threat of physical violence, honestly.
Right. And that's what we're tackling today.
Because the stakes in that specific environment, they change in a matter of seconds.
They really do.
When you introduce hostility and aggression into those diagnostic, muddy waters, that traditional medical surgical approach just completely shatters.
You can't just run a lab test to tell you if a patient is about to throw a chair.
No, you can't. You rely entirely on your clinical judgment, your understanding of the underlying pathophysiology, and your ability to read the microexpressions of human behavior.
Which is the core mission of our deep dive today. If you are a nursing student staring down the barrel of the NCLEX, or a psychiatric nurse prepping for a brutal night shift, or just an intensely curious learner trying to decode human behavior.
We're glad you're here.
Yes. We are treating this next hour as an elite clinical mentorship. We are taking the comprehensive clinical data on managing hostility and aggression, and we're filtering it strictly through the 80-20 rule.
Because you can't memorize everything.
Exactly. We are mining for the 20% of the concepts, the mechanisms, the pharmacology, the emergency protocols that will yield 80% of your clinical understanding, to keep you and your patients safe.
And we really have to start by dismantling the single biggest misconception that popular media has fed us.
Oh, the Hollywood stereotype.
Yeah, the Hollywood stereotype. If you watch television or movies, the psychiatric patient is almost exclusively portrayed as inherently violent, unpredictable, and harboring malice.
Like they're always the villain.
Right. The narrative is just heavily sensationalized.
Yeah.
But the statistical reality, it flips that script entirely.
It does.
Individuals with psychiatric disorders are exponentially more likely to be the victims of violence or to inflict harm upon themselves than they are to harm another person.
Yeah, that's a huge point.
Suicidal ideation and self-directed harm dominate the clinical landscape far, far more than outward aggression.
I mean, the media wants the Joker archetype, but the clinical reality is profound vulnerability.
Exactly.
The vast majority of psychiatric clients are not aggressive, but when hostility and physical aggression do manifest on the floor, it tests the absolute limits of the nursing staff.
It's terrifying if you aren't prepared.
It is. So the foundational shift for anyone working in this space is, moving away from a security guard mentality and anchoring yourself in a clinician mentality.
Right. You're a nurse, not a bouncer.
Exactly. You have to view the aggression not as a moral failing or inherent evil, but as a symptom.
It's a distress signal.
Yes, it's a distress signal of a neurochemical imbalance, a trauma response, or just a catastrophic failure of coping mechanisms.
And that paradigm shift, it dictates everything we are going to discuss today. Because if you view the patient as an adversary, you will invariably escalate the situation.
You'll make it worse.
Always. But if you view the aggression as a pathophysiological or psychological symptom, well, then you can actually intervene therapeutically.
So let's start with the basic vocabulary, because in everyday life, people use the words anger, hostility, and aggression completely interchangeably.
They treat them like synonyms.
Right. But in a clinical chart or on a board exam, blurring those definitions will cost you dearly. We really need to look at the evolutionary biology of anger.
Let's do it.
Because it isn't a pathology, right? It's a deeply ingrained survival mechanism. When someone experiences a real or perceived provocation, an injustice, or a threat, the amygdala sounds the alarm.
It acts as the brain's raw threat detection center. And the moment that alarm sounds, it activates the sympathetic nervous system.
The classic fight or flight cascade.
Exactly.
Oh.
Your hypothalamus signals your adrenal glands, pumping adrenaline and noradrenaline into your bloodstream. Your heart rate accelerates, your pupils dilate to take in more visual information.
Your bronchial tubes dilate to maximize oxygen intake.
Right. And blood is rapidly shunted away from your digestive organs and pushed directly into your major skeletal muscle groups.
So your body is literally preparing to fight for its life or, run a sprint.
Yeah, the physical vehicle is prepped.
So the emotion of anger is just the psychological experience of that physiological alarm bell.
That's a great way to put it.
And if a person can process that sympathetic arousal and express it assertively, anger is actually a highly productive force.
It really is. It drives conflict resolution, sets boundaries, and solves problems.
The pathology only enters the picture when this massive biological energy is mishandled. It either gets buried or it explodes inappropriately.
And burying it, suppression has devastating physiological consequences.
Oh, let's unpack that.
Well, there is a deeply rooted cultural expectation, particularly for women and historically marginalized groups, to constantly suppress the expression of anger to maintain social harmony.
To avoid being labeled as difficult.
Right. But you cannot just will away the sympathetic nervous system. If you deny the anger, the adrenaline and cortisol don't magically evaporate.
They don't just disappear.
No, they remain in the system.
And I want to look closely at the cardiovascular toll of that because it is shocking. We say holding in anger is bad for you, but clinically, what is actually happening?
It's physical damage.
Right. The chronic, sustained release of cortisol and catecholamines essentially acts like sandpaper on the inner lining of your blood vessels.
Oh, yeah, sandpaper.
Over time, that chronic sympathetic arousal damages the endothelial lining. It promotes macrophage infiltration, it accelerates plaque formation, and it leads directly to severe hypertension, coronary artery disease, and, a significantly elevated risk of ischemic strokes.
It's a silent killer.
We also see it manifest as severe migraine headaches, gastric ulcers, and profound treatment-resistant depression.
Because depression is often conceptualized as anger turned inward.
Wait, really? Anger turned inward?
Yes. The psychological energy required to constantly monitor and suppress a powerful emotion like anger. It exhausts the brain's resources. It leads to low self-esteem and deep lethargy.
That makes so much sense.
So assessing for this suppressed, inward-turning anger is a massive part of holistic nursing. You might be treating a patient for chronic ulcers, but the root cause is a decade of unexpressed rage.
Okay, so that is the danger of suppression. On the flip side, the other end of the spectrum is the inappropriate external expression of this energy.
And this is where we separate hostility from physical aggression.
Right. Hostility is verbal. It is the patient yelling, swearing, being deliberately uncooperative, or violating unit rules just to create discomfort.
The defining clinical characteristic of hostility is the intent to intimidate.
To intimidate, yeah.
When a patient is screaming that you are an incompetent nurse, they are experiencing feelings of profound powerlessness, and they are using verbal abuse to reclaim some sense of control by making you feel small.
Hostility is the psychological precursor.
Exactly.
If the clinical staff fails to recognize and de-escalate that verbal intimidation, it almost inevitably crosses the physical threshold.
And that brings us to physical aggression, which is behavior intended to attack, injure, or destroy property.
But both hostility and physical aggression share the same underlying motivation, right?
They do. It's about punishing someone, causing emotional or physical harm, or forcing another human being into compliance.
Which brings up one of the most persistent and frankly dangerous myths in behavioral psychology. I call it the catharsis myth.
Oh, this is a huge one for exams.
I want to dive really deep into this because it is one of the most highly testable concepts for nursing students and a massive trap on the floor.
Yes. Listen closely to this part.
The cultural narrative tells us that anger is like steam in a pressure cooker, the hydraulic model. If the pressure builds too high, it explodes.
Right.
So, pop psychology suggests we need to provide a safe release valve. If a patient is pacing, furious, and highly agitated, the instinct is to tell them to go hit a punching bag, scream into a pillow, or tear up a phone book.
Let them exhaust that physical energy safely, right?
Exactly. It sounds incredibly intuitive.
Which is why it is such a dangerous misconception. The answer to using cathartic, aggressive activities as an intervention is a categorical, absolute no.
No punching bags.
No punching bags. It is fully contraindicated for angry clients.
Mm-hmm.
We have moved far beyond the hydraulic model of the mid-20th century because modern neurobiology, like functional MRI scans, shows us exactly what happens when you engage in aggressive physical acts, even against an inanimate object.
It all comes down to neuroplasticity, right? Hebb's law.
Exactly.
Yeah.
Neurons that fire together wire together.
So when you hand an angry patient a punching bag, you aren't draining the anger out of them.
Not at all.
You are reinforcing the neural pathways that connect the emotion of frustration to the physical act of striking out.
You are actively training their brain that violence is the appropriate motor response to the sympathetic nervous system's arousal.
That is so counterintuitive, but it makes perfect neurological sense.
Furthermore, hitting the punching bag keeps the heart rate up and adrenaline flowing. It sustains the fight-or-flight cascade. It fuels the fire rather than extinguishing it.
Okay, so NCLEX logic here.
Yes.
Yes.
If you see an exam question asking for the priority intervention for an angry pacing client, and a distractor option suggests provide a safe object for the client to strike to release energy.
You must eliminate it immediately.
Immediately, it is a safety violation.
So the clinical challenge is, how do we help them burn off the massive influx of catecholamines without practicing violence?
The evidence-based alternative is to encourage activities that require physical exertion but are entirely non-aggressive.
Like what?
Taking a brisk walk up and down the hallway is phenomenal. It metabolizes the adrenaline without mimicking a violent strike.
Okay, walking.
But even more importantly, we need to engage the frontal lobe to regain control over the amygdala.
We need to pull the patient out of the primitive emotional midbrain and back into the rational executive functioning part of their brain.
This is where therapeutic communication becomes an active medical intervention.
Let's talk about that.
We use cognitive behavioral techniques. We teach them to reframe the situation. And most critically, we role model assertive communication, specifically through the use of I statements.
The I statement is just brilliant in its simplicity because it forces the brain to analyze its own emotional state rather than just lashing out.
Exactly.
Like if a patient is angry because their pass was denied, the hostile reaction is, you doctors are all liars, you're trying to keep me locked up forever.
That is an attack. It puts the staff on the defensive.
Right. But the assertive alternative we teach is, I feel incredibly frustrated and helpless when I am told I cannot go home for the weekend.
It takes total ownership of the emotion. It names the feeling, describes the specific trigger, and leaves no room for debate. You cannot argue with how someone feels.
And the nursing staff must relentlessly model this, right?
Relentlessly. If a patient is standing over the medication cart screaming at you, the worst thing you can do is snap back with, "Stop being so abusive, go to your room."
Right, because now you have entered a power struggle. You've met hostility with hostility.
You've lost your clinical leverage.
So the clinical response is to hold your ground, regulate your own breathing, and say, I feel disrespected when you raise your voice at me, and I need you to step back and lower your volume so I can understand what you need.
You are setting an ironclad boundary, but you are doing it while actively modeling the exact emotional regulation the patient lacks.
But, everything we have just discussed assumes we are dealing with a relatively intact neurotypical brain that is simply struggling with coping skills and emotional regulation.
That's a big assumption on a psych unit.
It is. We have to pivot and look at what happens when the actual physiological hardware of the brain is damaged or when the fundamental neurochemistry is severely altered.
Why do some people respond to a minor annoyance with a sigh, while others respond by throwing a table across the room?
Exactly. We have to open the hood and look at the engine. Researchers have spent decades looking for a single violence gene, and, well, they failed. It doesn't exist.
Aggression is highly polygenic and incredibly complex.
But what they have found are massive correlations with specific neurotransmitter imbalances. To understand how to medicate aggression later, we first have to understand the core pathophysiological problem.
The neurochemistry.
Right. Let's look at the three major neurochemical players: serotonin, dopamine, and norepinephrine.
Let's start with serotonin. It is arguably the most critical component when discussing impulse control. Serotonin acts as the brain's major inhibitory neurotransmitter when it comes to behavior. Think of serotonin as a neurological traffic cop.
Okay, a traffic cop.
When the amygdala senses a threat and wants to trigger an aggressive outburst, serotonin binds to specific 5-HT receptors and essentially holds up a stop sign.
It hits the brakes?
Right, it delays the impulse long enough for the frontal lobe to assess the situation and say, wait, that person didn't bump into us on purpose? The hallway is just crowded. Stand down.
So if a patient has chronically low serotonin levels, the traffic cop is off duty.
The inhibitory brakes are completely gone.
The impulse to strike out travels unimpeded. And this explains a clinical phenomenon that surprises a lot of nursing students: the intense link between severe depression and sudden aggression.
Yes, we traditionally view major depressive disorder as psychomotor retardation, profound sadness, and a lack of energy.
Just lying in bed.
Right. But many severely depressed patients suffer from extreme serotonin depletion. This leads to what are clinically termed anger attacks.
Anger attacks?
Yeah. These are sudden, blindingly intense spells of rage where the depressed individual feels emotionally trapped. They might experience a minor annoyance like dropping a spoon on the floor and react with a terrifying verbal explosion of rage.
Because the threshold for frustration is 0 and they have no serotonin to inhibit the reaction.
Exactly. But the tragedy of the anger attack is the immediate aftermath. Because it isn't driven by malice, the explosion is followed by crushing remorse and guilt, which ironically deepens the depression.
Wow. So low serotonin is the absence of brakes. Let's look at dopamine and norepinephrine.
If serotonin is the brakes, dopamine and norepinephrine are the fuel injectors.
Whoa, boy.
Increased activity in the mesolimbic dopamine pathway is directly associated with heightened impulsivity, grandiosity, and violent behavior.
So what does dopamine actually do in that moment?
Dopamine assigns salience or importance to stimuli. When dopamine is excessively high, every whiner look, every neutral comment from a nurse is perceived by the patient as intensely meaningful and highly threatening.
Exactly. Norepinephrine, meanwhile, heightens the physiological arousal. It makes the patient hypovigilant and physically primed for war.
So the absolute worst-case scenario for aggressive behavior is a patient with a massive depletion of serotonin combined with a surge of dopamine and norepinephrine.
They are hyper-aroused, interpreting everything as a threat, and they have 0 neurological ability to inhibit their impulses.
It's a perfect storm. And then we layer on structural brain damage, the physical anatomy.
Traumatic brain injury, or TBI, fundamentally alters the capacity for self-regulation. We look specifically at damage to the frontal and temporal lobes and the limbic system.
Because the frontal lobe is our control center.
The frontal lobe houses our executive function. It is where judgment, empathy, consequence prediction, and social inhibition live.
Like the famous case of Phineas Gage.
Exactly.
The railroad worker who had an iron rod blown through his frontal lobe in the 1800s. He survived, but his personality changed entirely. He became impulsive, profane, and violently aggressive because the structural hardware that kept him civilized was physically destroyed. Right. When you are treating a patient with early-onset dementia or a severe TBI from a motor vehicle accident and they become hostile, it is crucial to recognize that they are not choosing to be difficult.
They literally lack the anatomical capacity to modulate their behavior.
Yes. And this brings us directly to identifying the high-risk populations on a given unit.
Okay, let's talk about risk factors.
As a nurse taking a report at the start of a shift, certain diagnoses should immediately elevate your vigilance regarding safety and potential escalation.
The first and arguably the most rigorously tested on exams is schizophrenia.
But not just a general diagnosis of schizophrenia.
Right. We are looking specifically at patients presenting with active paranoid delusions or command hallucinations. Let's walk through the subjective experience of that patient. Why are they a high risk for violence?
Because you have to step into their altered reality. A patient with paranoid schizophrenia genuinely, to their absolute core, believes that the world is lethal.
Subjective findings of intense fear.
Right. They might believe the nursing staff is part of a government conspiracy trying to poison their food, or that the patient in the next bed is an assassin. When they lash out and attack a nurse, it is rarely predatory.
In their mind, it is pure self-defense.
Exactly. They are fighting for their survival against perceived monsters.
And command hallucinations elevate that risk exponentially.
They do.
These are auditory hallucinations, voices, that specifically instruct the patient to perform an action. Sometimes the voice tells them to refuse their medication, but in severe cases, the voice commands them to harm themselves or to strike out at the person nearest to them.
The voice is often perceived as a divine or demonic authority that cannot be disobeyed without catastrophic consequences.
This dictates an absolute priority nursing assessment.
Let's talk about what the nurse does first.
If you have a patient with schizophrenia who is suddenly staring blankly, tilting their head as if listening to something you cannot hear, or mumbling to themselves,
You must assess the content of the hallucinations immediately.
you don't tiptoe around it.
No, you ask directly. Are you hearing voices right now? What are the voices telling you to do?
And if they admit to command hallucinations directing violence?
That is an immediate red flag psychiatric emergency. They require continuous one-on-one observation and likely emergency pharmacological intervention. You cannot negotiate with hallucination.
Beyond schizophrenia, we also look closely at dementia and delirium.
Delirium is a medical emergency characterized by an acute, fluctuating change in mental status. Dementia is a chronic, progressive decline.
But both involve profound confusion and disorientation.
Imagine waking up in a strange room, surrounded by people in scrubs speaking a language you can't quite process, holding needles and telling you to take off your clothes.
The terror would be absolute.
The aggression we see in these patients is almost entirely fear-based lashing out.
We also must flag intoxication and withdrawal. Alcohol and illicit substances actively suppress the frontal lobe, stripping away inhibitions.
And finally, severe personality disorders, specifically antisocial personality disorder and borderline personality disorder.
Right, in these cases, the patient's core psychological structure is defined by profound emotional dysregulation, an inability to tolerate distress, and a long history of utilizing manipulation or hostility to get their needs met.
There's one very specific, rare, but highly testable psychiatric diagnosis we need to unpack. Intermittent explosive disorder, or IED.
IED. Let's break this down.
It is distinct from everything we just discussed. It isn't driven by psychosis, dementia, or a personality disorder. It is an impulse control disorder characterized by discrete, sudden episodes of massive aggressive impulses resulting in serious assaults or the destruction of property.
The demographics and the cycle of IED are fascinating. It typically manifests between late adolescence and a person's 20s, most frequently in males.
Right.
These are often individuals who harbor deep-seated feelings of uselessness, inadequacy, or ineffectiveness in their daily lives. But the defining clinical criteria, the phrase you will absolutely see on a nursing exam, is that the violent outburst is grossly disproportionate to any preceding provocation.
That is the key differential. Someone might accidentally step on their shoe, or a cashier might be slow returning their change. A neurotypical response might be a sigh or a brief verbal complaint.
The patient with IED responds by completely losing contact with rational thought.
They might pick up a chair and smash it through a window or brutally assault the person next to them. The reaction is an atomic bomb in response to a firecracker trigger.
But the psychological cycle of the IED episode is what makes it so tragic, and how we differentiate it from antisocial personality disorder.
With an antisocial patient, violence is often calculated, predatory, and lacks any remorse.
But the IED cycle is completely different.
It follows a rigid pattern. The individual experiences a rapidly building period of intense internal tension and physical arousal. They feel like a coiled spring about to snap.
And then the outburst.
The violent outburst occurs, and for a fleeting, terrifying moment, the physical explosion provides a profound sense of relief. It releases the unbearable tension.
Not then.
But that relief is instantly replaced by devastating, crushing remorse, embarrassment, and self-hatred.
Between these episodes, the individual shows absolutely no signs of aggression or malice. They are often deeply apologetic and terrified of their own behavior.
The diagnosis of IED is only given when this specific tension-release remorse cycle is present, and no other comorbid psychiatric disorder like a manic episode of bipolar disorder or schizophrenia can explain the outbursts.
We have spent a lot of time on the biological and pathological drivers, but to be a truly elite clinician, you must layer cultural competence over the neurobiology.
Absolutely.
How a human being processes and expresses the emotion of anger is heavily dictated by the cultural framework they were raised in. If a culture views outward aggression as an unforgivable taboo, that energy will mutate and find another exit.
The sources provide incredible examples of recognized cultural syndromes. We cannot assume that a patient presenting with bizarre physical symptoms or sudden dissociation fits neatly into our Western DSM-5 categories.
Let's look at the Korean syndrome of Hwabyeong.
Hwabyeong literally translates to anger syndrome or fire illness. It is a profound somatic condition primarily observed in older Korean women.
And what's the core problem there?
It is deeply rooted in the cultural mandate to suppress anger, particularly in the face of long-term oppression, patriarchal structures, or family trauma. Because the culture historically forbade these women from vocalizing their rage, the massive sympathetic nervous system arousal we discussed earlier literally attacks the body.
So a Western-trained nurse might assess a patient with Hwabyung and see a constellation of physical complaints.
Like heavy, labored sighing, severe stabbing abdominal pain, intractable insomnia, and a feeling of a physical mass in the throat or chest.
The risk is that the provider will misdiagnose it as major depressive disorder or a standard somatic symptom disorder, prescribe an SSRI, and completely miss the root cause.
Right. The cure isn't just an antidepressant. It is finding a culturally acceptable avenue for the patient to finally process decades of suppressed fire.
Then we have cultural syndromes that manifest as external, highly volatile aggression. Buffet de l'errant is a condition documented in West Africa and Haiti.
It presents as a sudden, explosive outburst of agitated and aggressive behavior. The patient experiences marked confusion, extreme psychomotor excitement, and sometimes visual and auditory hallucinations.
To an untrained eye in an emergency department, this looks exactly like a first-break schizophrenic episode or severe substance intoxication.
But Buffet de l'errant is considered a distinct, culturally influenced transient state, often triggered by severe psychosocial stress that can resolve as quickly as it appears.
And finally, the sources highlight the phenomenon of amok. We use the phrase running amok so casually in English, but its origin is chilling.
It really is.
Historically documented in Malaysia, but observed in various forms globally, amok is a severe dissociative episode. It typically involves a male who experiences a perceived slight, profound insult, or loss of face. Instead of reacting immediately, they enter a period of intense, withdrawn brooding.
They are completely silent, internalizing the shame. And then, without any immediate warning, they snap into a dissociative state and launch into a sudden, unprovoked, homicidal rampage directed at anyone and anything in their path.
The episode only ends when the individual is physically restrained or exhausted, and they typically emerge with total amnesia of the violence.
Understanding these cultural frameworks prevents us from indiscriminately slapping Western psychiatric labels onto complex, culturally mediated trauma responses.
So we have established the neurobiology, the high-risk populations, and the cultural context. We know why aggression happens.
Now for the how.
Exactly. We must transition to the absolute core of psychiatric nursing practice, how it happens in real time on the floor. Aggressive behavior in a clinical setting is almost never a sudden lightning strike from a clear blue sky.
It follows a highly predictable, mechanical, 5-phase aggression cycle.
If you take away only one conceptual framework from this entire deep dive, let it be the mastery of these 5 phases.
Your ability to correctly identify which phase the patient is currently in dictates the exact nursing intervention you must deploy.
Because if you apply a phase 3 intervention to a phase 1 behavior, you will escalate the patient yourself.
And if you try to use a phase 1 intervention during phase 2, someone is going to get hurt.
Let's walk through this cycle with hypervigilant detail. Phase 1 is the triggering phase, the spark.
The triggering phase occurs when an event or circumstance in the environment initiates the client's internal response.
What kind of triggers?
This trigger can be external and obvious, a nurse denying a request for a smoke break, a loud argument down the hall, or a meal arriving late. Or the trigger can be internal, a sudden spike in paranoid thoughts, a wave of chronic pain, or the onset of command hallucinations.
As the nurse, you are constantly scanning the milieu for the behavioral expected findings of phase 1. Yeah. You are looking for the subtle physical leakage of that sympathetic nervous system arousal.
Right. What does the patient look like? You see restlessness, they start pacing the hallway, you notice muscle tension, their jaw clenches, their shoulders hike up to their ears, their respiratory rate increases.
Behaviorally, their voice volume ticks up a notch. They become irritable, snappy, and they may begin explicitly verbalizing anger or grievances.
The clinical analogy here is smelling smoke in a house. You don't call the fire department and start hacking through the walls with an axe. That is a massive overreaction.
But you absolutely do not ignore the smell.
You drop what you are doing, go to the kitchen, and turn off the stove. Your priority nursing intervention in the triggering phase is to de-escalate the emotion before the frontal lobe completely goes offline.
Let's talk therapeutic communication here. You approach the client in a calm, non-threatening, open posture. Keep your hands visible and relaxed.
Do not stand directly face to face, which can be perceived as confrontational. Stand at a slight angle.
Use clear, simple, and short statements. When anxiety spikes, cognitive processing speed plummets. They cannot process complex paragraphs.
You convey genuine empathy and validate their reality. I can see that you are incredibly frustrated that your phone privileges were revoked. Let's talk about what happened.
Simultaneously, you are manipulating the physical environment. You must decrease environmental stimulation.
If the TV in the day room is blaring the news, turn it off. If there are other patients crowding around, direct them away. Ask the client if they would like to walk with you to a quieter area.
And clinically, this is the exact moment to offer PRN medications as needed, oral anti-anxiety or antipsychotic meds if they are ordered.
In phase 1, the patient still has enough executive function to recognize they're losing control and may willingly accept the medication to help themselves calm down.
But let's assume the trigger was too severe, or the PRN medication was refused or failed to absorb in time. The smoke turns into a visible flame. We cross the threshold into phase 2, the escalation phase.
The boiling point.
The physiological arousal is now overriding the cognitive systems. The expected findings shift dramatically.
The client's behavior indicates movement toward a total loss of behavioral control. Their face may become entirely flushed or dead pale as blood shunts to the muscles. The pacing turns into stomping.
They are yelling, swearing, and making explicit demands. You will see clenched fists, aggressive posturing, and perhaps throwing minor objects like a cup of water or a magazine.
But the most important hidden finding, the invisible reality that dictates your next move, is that the client's frontal lobe is now effectively offline.
They have lost the ability to solve problems, reason logically, or think clearly about consequences.
Which means attempting to deeply process their feelings or negotiate with them at this exact moment is a clinical error. It is useless.
You cannot logic someone out of a state that they didn't logic themselves into.
The nursing intervention must pivot completely. The soft, empathetic, exploring approach of phase 1 is abandoned. The nurse must now adopt a directive approach.
You must become the external boundary that their internal brain can no longer provide. You use a calm, but deeply firm and authoritative voice.
You stop asking questions and start issuing simple, clear directives. John, your behavior is unsafe. You need to stop yelling and walk to your room for a timeout right now.
And this is where the textbook introduces a highly tested and sometimes controversial protocol called the show of force.
Yes, the show of force.
When a patient hits the escalation phase, the primary nurse signals for help and 4 to 6 trained staff members quietly gather in the immediate area.
They do not instantly swarm or surround the patient. They stand by within the patient's line of sight, but at a respectful, safe distance while the primary nurse continues to direct the patient.
Now, I want to challenge this from a human perspective. If I am paranoid, agitated, and feeling cornered, and suddenly 6 large orderlies and nurses appear and stand silently in the hallway staring at me, isn't that going to look like an ambush?
It is intimidating, and it is a delicate balance, but the clinical psychology behind it is profound.
Tell me more.
When a patient is escalating, part of their terror comes from the sudden realization that they are losing control of their own mind and body. They feel like a car speeding toward a cliff with no brakes.
Okay.
The sudden, coordinated, calm appearance of a unified team provides a visual psychological anchor.
It's an externalization of ego boundaries.
Exactly. The unspoken message of the show of force is, we see that you are losing control, but we are in control. This environment is safe, and we have enough collective strength to ensure that you will not be allowed to hurt yourself or anyone else here.
Time and time again, the mere visual presence of the staff allows the patient to surrender the fight.
It gives them permission to stand down, accept the PRN medication, and take the time out, because they realize the environment can contain their chaos.
But sometimes, despite the flawless execution of phase 1 and phase 2, the pathology is too strong. The boiling point tips over. We enter phase 3, the crisis phase.
This is a code situation. It is a psychiatric and medical emergency.
What are the expected findings here?
The expected finding in the crisis phase is the absolute total loss of emotional and physical control. The patient is engaged in active physical violence. They are destroying property, throwing heavy objects, kicking, hitting, biting, spitting, or attempting to weaponize anything in the room.
They possess zero ability to communicate clearly. You are dealing entirely with the brainstem and the amygdala.
So what is the absolute priority nursing action?
You drop all attempts at verbal de-escalation. The priority is immediate physical safety for the patient, the staff, and the other clients on the milieu.
This is when seclusion or physical restraints are initiated. But we must be brutally clear. Applying physical restraints is one of the highest risk procedures in medicine.
It is fraught with legal, ethical, and physical danger. You do not just tackle a patient. There is a rigid protocol.
Never attempt to physically restrain a violent adult patient with only 1 or 2 staff members. It guarantees injury to the staff and often results in severe joint dislocations or asphyxiation for the patient.
The golden rule is 4 to 6 highly trained staff members.
The coordination must be flawless. 1 staff member is explicitly assigned to control each limb, that is 4 people. A 5th staff member is assigned solely to protect, control, and monitor the head and airway. A 6th may be required to stabilize the torso.
That perfectly highlights why you called the staff during the escalation phase.
Right. If you wait until the crisis phase to hit the panic button, you are fighting a violent patient alone for 3 minutes while help runs down the hall. Anticipation is everything.
Once the patient is safely transported to the seclusion room and placed in 4-point leather restraints on the specialized bed frame, the clock starts ticking on massive legal and medical requirements.
2 critical actions must happen simultaneously. First, the nurse must obtain a provider's order for the restraints immediately, adhering strictly to hospital policy and state law, usually within 15 to 30 minutes of application.
You cannot legally hold a patient in restraints without an active, time-limited physician's order. It is considered false imprisonment and battery.
And second, because the patient is in a state of extreme sympathetic hyperarousal and fighting the restraints, which can lead to sudden cardiac death or rhabdomyolysis, you must obtain an order for chemical restraints.
You will need to administer rapid-acting intramuscular or IM medications.
Because a patient in 4-point restraints is not going to politely swallow a pill with a cup of water.
We will break down exactly which IM medications are pulled from the pixies in just a moment. But let's follow the behavioral arc. The IM medications are administered, the drugs cross the blood-brain barrier, the patient physically exhausts their adrenaline reserves.
We transition into phase 4, the recovery phase, the cool down.
What are the expected findings as they emerge from the crisis?
You will observe a visible decrease in muscle tension. Their respiratory rate slows. The flesh skin returns to normal. They may close their eyes or speak in a lower, quieter volume. They are slowly regaining access to their rational communication skills and reality testing.
The nursing interventions here shift back to support. You help the client relax, you provide hydration, and you constantly monitor their vital signs and circulation in the restraints.
Once they are coherent, you calmly explore alternatives. When you feel that tightness in your chest next time, what can we do differently to help you before it gets to this point?
But phase 4 is not just about the patient. It includes a mandatory critical intervention for the clinical team, the staff debriefing.
A physical takedown is a massive traumatic event for everyone involved, including the nurses. The charge nurse must pull the involved staff together, assess everyone for hidden physical injuries, and conduct a structured debriefing.
Why is this so vital for unit safety?
Because it is the only way practice improves. The team must dissect the event. What was the exact trigger? Did we miss the subtle signs in phase 1? Did the show of force in phase 2 happen fast enough? Was the physical hold coordinated safely? What can we change to prevent this tomorrow?
Without debriefing, trauma festers, burnout accelerates, and clinical mistakes are repeated.
Which brings us to the final step of the cycle, phase 5, the post-crisis phase, the aftermath.
The physical restraints have been removed. The patient has met the safety criteria. What are the behavioral findings?
The sympathetic storm is completely past. The expected findings are usually profound remorse, apologies, crying, and quiet withdrawn behavior. The patient is processing the wreckage of their own actions.
Now, I want to address a deeply ingrained human instinct here. A patient just terrified the unit, punched a wall, spit at a technician, and required 5 people to wrestle them into a bed.
Yeah.
Human nature dictates that once things are calm, the authority figure should sit them down and deliver a stern lecture. Shouldn't the nurse make absolutely sure the patient knows exactly what they did wrong and emphasize that it can never happen again?
Doing so is a catastrophic clinical failure.
Wait, really?
It is one of the most common mistakes novice psychiatric nurses make, and it is a massive trap on the NCLEX. The priority intervention in the post-crisis phase is simple reintegration into the milieu. You absolutely do not lecture, chastise, scold, or demand performative apologies from the patient.
But doesn't that mean we aren't holding them accountable for violence?
It is not a question of accountability. It is an understanding of the psychological shame cycle. The patient is already experiencing crushing internal remorse. Their self-esteem is at rock bottom.
Right. They feel terrible.
If a nurse uses their position of power to lecture and shame the patient, it destroys the therapeutic alliance. It proves to the patient that the nurse views them as a bad child, not a suffering adult.
And more dangerously, shaming pushes the patient into a defensive posture.
Yes. That defensive anxiety can instantly trigger the sympathetic nervous system, rocketing the patient straight back into phase 1 or phase 2 of the aggression cycle. You provide calm, objective feedback, but you never punish them emotionally.
So that is the 5-phase cycle: triggering, escalation, crisis, recovery, post-crisis. Throughout that cycle, particularly in phase 3, we mention the reliance on emergency pharmacology.
It is time to open the crash cart and dive into the must-know medications for hostility and agitation.
When the brain is on fire, what specific tools do we use to put it out? How do they work, and what are the lethal side effects?
Emergency psychiatric pharmacology is a high-wire act. The goal is rapid, profound stabilization with the absolute minimal amount of harm. For acute, severe agitation, especially when complicated by psychosis, there is a legendary, highly tested combination of medications considered the gold standard.
In clinical slang, it's often referred to as the B52, or variations of a chemical restraint cocktail. We are talking about the simultaneous administration of an antipsychotic and a benzodiazepine.
Specifically, haloperidol and lorazepam.
Let's break down the mechanics, starting with haloperidol.
Haloperidol, or Haldol, is a high-potency, first-generation typical antipsychotic. To understand why we give it, you have to know its mechanism of action. Haldol is a potent antagonist of the D2 dopamine receptors in the brain. It binds to the receptors and blocks dopamine from transmitting its signal.
Going back to our earlier neurobiology, we established that a massive surge in dopamine in the mesolimbic pathway acts as the amplifier for paranoia, grandiosity, and violent reactivity. Dopamine is the fuel injector.
Haldol aggressively cuts the fuel line.
Precisely. It is incredibly effective at rapidly resolving acute psychotic symptoms. If a patient is attacking the staff because command hallucinations are screaming in their ear, Haldol turns the volume of those voices down to a whisper, often within 20 to 30 minutes when given intramuscularly.
But Haldol alone isn't always enough to stop the physical thrashing. That is why it is almost universally paired in the same syringe with lorazepam, brand name Ativan.
Lorazepam is a fast-acting benzodiazepine. Its mechanism of action is entirely different from Haldol.
Lorazepam binds to an allosteric site on the GABA-A receptor. GABA is the brain's primary inhibitory neurotransmitter.
By binding to the receptor, lorazepam enhances the effect of GABA, allowing massive amounts of negatively charged chloride ions to flood into the neurons.
This hyperpolarizes the cell, making it incredibly difficult for the neuron to fire.
In simple terms, it causes profound, rapid sedation of the entire central nervous system. If Haldol cuts the psychosis fuel line, Ativan slams on the heavy emergency brakes. It forces the muscles to relax and the brain to sleep.
Now, the sources mention a specific protocol for using lorazepam on its own.
Yes, clinical judgment is key here. If you have a patient who is wildly agitated and aggressive, but they are not psychotic, they aren't hearing voices, they aren't paranoid, they're just furious and dysregulated, using a heavy antipsychotic like Haldol exposes them to unnecessary risks.
In those non-psychotic cases, lorazepam alone is the first-line choice. The highly testable dosage to know is 2 milligrams given every 45 to 60 minutes until the agitation is controlled.
But administering powerful central nervous system depressants is fraught with danger. Let's discuss the absolute red flags. Let's start with the benzodiazepine paradox.
Oh, this is critical.
We just established that Ativan forces the brain to slow down and sedates the patient. But the clinical text highlights a massive warning regarding benzodiazepines in specific populations.
It is one of the most terrifying phenomena a nurse can witness. Benzodiazepines generally work beautifully to reduce irritability, particularly in older adults with dementia. However, in certain aggressive clients, specifically those with severe personality disorders, borderline traits, or a heavy history of substance abuse, benzodiazepines trigger a paradoxical reaction.
Meaning the drug does the exact opposite of what the textbook says it should do.
Exactly. To understand why, you have to remember that alcohol also acts heavily on GABA receptors. When you give these specific patients Ativan, it acts like a massive shot of liquor. It sedates the highly sensitive frontal lobe first. The frontal lobe was the only thing providing their last shred of social inhibition. With the frontal lobe knocked out by the drug, the primitive aggressive midbrain takes over completely.
The patient becomes significantly more aggressive, violently unpredictable, and utterly uninhibited.
If you give a dysregulated borderline patient 2 milligrams of Ativan, and 10 minutes later they are suddenly tearing the room apart with renewed vigor, you must recognize that you are witnessing a paradoxical disinhibition, not a failure of the drug's potency.
That requires razor-sharp clinical awareness. Okay, what about the red flags for haloperidol? The typical antipsychotics are notorious for their side effect profiles.
The mechanism of action is the problem. Halol blocks dopamine to cure psychosis, but dopamine is also required in a completely different part of the brain, the basal ganglia and the substantia nigra, to coordinate smooth, purposeful muscle movement.
When you aggressively block dopamine everywhere, you trigger extrapyramidal symptoms, or EPS.
These are the horrifying movement disorders. We need to define the 3 acute forms of EPS because a nurse must be able to spot them instantly.
First is acute dystonia. This is a severe, intensely painful, involuntary muscle spasm, most commonly affecting the neck, face, and tongue. A patient's neck might violently twist to the side and lock toward a callus, or their eyes might roll back into their head.
Second is akathisia. This is often misdiagnosed by new nurses as worsening anxiety. It is a profound, agonizing sense of internal restlessness. The patient feels like their blood is vibrating.
They literally cannot stop pacing, shifting weight, or rocking. It is so psychologically distressing that it has been linked to sudden suicidal impulses.
And third is pseudo-Parkinsonism. The dopamine blockade mimics Parkinson's disease. You see a stiff, shuffling gait, a pill-rolling tremor in the fingers, a mask-like blank face, and drooling.
If my patient gets a shot of Haldol in the crisis phase, and 2 hours later during the recovery phase, their jaw locks up, their neck twists violently to the ceiling, and they are drooling. Acute dystonia. What is my immediate priority nursing intervention? I can't just tell them to relax. How do I fix the neurochemistry?
You must administer the antidote. The reversal agent for acute EPS is a fast-acting anticholinergic medication. The gold standard is benztropine, brand name Cogentin.
Alternatively, you can use diphenhydramine Benadryl.
By rapidly blocking acetylcholine, Cogentin restores the delicate seesaw balance between dopamine and acetylcholine in the basal ganglia, and the muscle spasms resolve, often within minutes. This is why you will almost always see an order for PRN Cogentin listed right beneath an order for Haldol.
So for the acute crisis, Haldol to block dopamine, Ativan to boost GABA watching out for the paradox and Cogentin in your back pocket to rescue them from EPS. That handles the emergency, but what about long-term prevention?
The sources briefly outline maintenance medications to stabilize the underlying disorders so these crises stop happening.
Maintenance requires a different approach. If the aggression is driven by the severe mood swings of bipolar disorder, conduct disorders, or intellectual developmental disabilities, lithium is a frontline mood stabilizer.
And the absolute red flag for lithium.
Lithium toxicity. Lithium is a salt, and it shares an incredibly close relationship with sodium in the kidneys. It has a dangerously narrow therapeutic index. The nurse must constantly monitor serum blood levels.
If the patient becomes dehydrated or their sodium drops, the kidneys hoard lithium, leading to toxicity. The nurse must monitor for severe diarrhea, persistent vomiting, ataxia, coarse tremors, and profound confusion.
For aggression associated with dementia, psychosis, or severe personality disorders, we often see anticonvulsant medications repurposed as mood stabilizers, specifically carbamazepine or Tegretol and Valproate Depakote.
And finally, the cornerstone of modern maintenance, the atypical second-generation antipsychotics, drugs like clozapine, risperidone, olanzapine, and ziprasidone.
These atypicals are preferred for long-term management because they target both dopamine and serotonin receptors, which helps balance mood while controlling psychosis.
Most importantly, because their dopamine blockade is weaker and more targeted than Haldol, the risk of developing those torturous EPS movement disorders is significantly lower.
We have spent a massive amount of time dialing in the internal neurochemistry, but drugs only work inside the body. What about the whoosh outside the body? How does the physical space that the nurse and the patient share act as a treatment or a trigger?
Let's move into milieu management, the realities of the workplace and the nurse's internal landscape.
The milieu is a French term that refers to the entire therapeutic environment of the psychiatric unit. The physical layout, the schedule, the lighting, and the emotional tone of the staff all constitute the milieu.
The text points out a surprising fact. While physical crowding can increase tension, a lack of psychological space is a far more potent trigger for aggression.
What does a lack of psychological space look like in practical terms on a unit?
It looks like institutional chaos. It means the patient has zero privacy. It means they cannot get uninterrupted rest because doors are slamming all night. It means the daily schedule is entirely unpredictable.
If a patient doesn't know what time meals are served, when they can see their doctor, or when their family can visit, they are stripped of all autonomy.
Unpredictability breeds profound vulnerability and frustration. And frustration, coupled with institutional boredom, rapidly escalates into hostility.
So proactive milieu management by the nursing staff is actually an anti-aggression intervention, providing strong, calm psychiatric leadership, establishing rigid, predictable daily schedules.
Organizing structured group activities, even simple things like a supervised card game or a morning meeting, gives patients a way to burn time and engage socially when they're at baseline.
Scheduling regular one-on-one interactions proves to the patient that you are interested in their well-being before they have to throw a chair to get your attention.
But we have to pivot to a deeply uncomfortable reality within the milieu. When we discuss hostility and aggression in healthcare, we instinctively assume the violence originates from the patients.
But the sources dedicate a highly specific portion of this chapter to a different, insidious form of violence. Violence from within the ranks, workplace hostility, bullying, and lateral violence among healthcare staff.
The old toxic adage that nurses eat their young, this isn't just an HR problem, it is a critical patient safety issue.
It is a pervasive, destructive phenomenon. The Joint Commission, JCAS, the primary accrediting body for healthcare organizations, has been aggressively tracking this.
In 2008, they issued a massive Sentinel event alert regarding intimidating and disruptive behaviors among medical staff. Why? Because when a seasoned charge nurse ruthlessly mocks a new graduate nurse, or a surgeon screams at an ICU nurse over a minor error, it annihilates the culture of safety.
The bullied nurse becomes terrified to ask questions, verify orders, or report mistakes. That communication breakdown leads directly to lethal medical errors, decreased patient survival rates, and the massive hemorrhage of qualified personnel from the profession.
And the Joint Commission has steadily escalated their response to this.
They had to. In 2016, JCHO formally categorized workplace bullying, also known as lateral or horizontal violence, as a critical threat to safety. This encompasses overt verbal abuse, public humiliation in front of patients, and insidious behaviors like work sabotage, deliberately withholding crucial report information that a colleague needs to do their job safely.
As of 2022, there is an absolute mandate. Every accredited hospital must implement a formal code of conduct defining acceptable behavior, and leadership must enforce a zero-tolerance policy. You cannot create a therapeutic healing milieu for psychiatric patients if the nursing staff is operating in a toxic, hostile war zone.
Speaking of environments, we also have to acknowledge the shift in modern psychiatric care. Due to severe bed shortages and insurance limitations, acute patients are being discharged from inpatient hospitals faster than ever before. Care is being pushed out into community-based settings, residential group homes, outpatient clinics.
And as acute patients move into the community, the risks to community healthcare workers skyrocket.
The sources highlight a specific initiative from Massachusetts called the ASACI program, the Assaulted Staff Action Program. It was formed out of necessity because staff in these community residential programs were experiencing staggering rates of physical assaults, verbal threats, and chronic intimidation from clients.
Over a 30-year span, this single program responded to over 10,650 documented patient assaults on staff.
The data showed the typical perpetrators in these community settings were often older male clients diagnosed with schizophrenia or younger clients suffering from severe personality disorders. The violence was usually exacerbated by non-compliance with their maintenance medications, the sudden denial of social services, or acute psychotic relapses.
So how do we protect these workers who don't have a secure hospital infrastructure around them?
The evidence points decisively away from passive education. Handing a community health worker a pamphlet on violence or making them watch a generic video is useless.
The solution is intensive behavioral skills training, or BST. BST focuses on muscle memory. It involves direct instruction, live modeling of de-escalation body language, rigorous hands-on role-playing practice, and continuous performance feedback.
The studies definitively prove that BST drastically improves staff confidence, competence, and safety when confronted with a potentially violent community client.
That brings us to the final concept in this section, and it is arguably the most profound clinical insight a psychiatric nurse can achieve: the concept of the nurse's internal milieu, your own self-awareness, countertransference.
Before you can hope to manage a patient's volatile anger, you must absolutely master your own.
This is what separates a technician from an expert clinician. You have to be ruthlessly honest with yourself about how you process fear and conflict. If a nurse is secretly terrified of a large, loud, angry patient, the nurse will consciously or unconsciously avoid that patient. They will skip their rounds, delay their medications, or cut conversations short.
And avoidance is the ultimate catalyst for escalation. The patient isn't stupid. They can feel the avoidance. They feel ignored. Their frustration compounds, and their behavior inevitably escalates because they realize they have to cause a scene just to force the staff to interact with them.
Conversely, if a patient is highly hostile, swearing at the nurse, insulting their intelligence or appearance, and the nurse responds with their own anger, if the nurse's ego is bruised and they take the insult personally, it instantly creates a toxic power struggle.
The nurse loses all therapeutic leverage, the professional boundary collapses, and the situation spirals into a street fight.
The clinical reality is this. Not taking a patient's aggression personally is not a personality trait you were born with. It is a highly disciplined, required clinical skill. You must consciously remind yourself, in the heat of the moment, that the patient's vitriol is a symptom of their trauma, their psychosis, or their neurochemistry. It is not a commentary on your worth as a human being or your skill as a nurse.
Achieving that level of Zen requires constant work. It requires active participation in clinical supervision, utilizing the debriefing sessions we discussed, leaning on the experience of senior peers, and constantly analyzing your own triggers, biases, and conflict resolution defaults.
We have covered a colossal amount of complex clinical ground. We have unpacked the evolutionary biology of the sympathetic nervous system, the cardiovascular toll of suppression, the dopamine-serotonin axis, the deep cultural nuances of syndromes like AMOC, the rigid steps of the 5-phase cycle, the D2 antagonism of Haldol, and the systemic dangers of lateral violence.
It is time to fulfill the promise we made at the beginning of this hour. It is time to synthesize all of this data using the 80-20 rule. If you are walking into an NCLEX exam tomorrow, or stepping onto a locked psychiatric unit in an hour, what is the absolute undeniable core 20% of knowledge that you must master?
Let's break it down into the most testable, high-yield categories. First, must-know safety risks. The catharsis myth is paramount. Encouraging an angry patient to hit a punching bag, punch a pillow, or engage in violent physical release is strictly contraindicated.
It strengthens neural pathways for violence and keeps the sympathetic nervous system engaged. Do not choose it on an exam. Choose interventions that require non-aggressive physical exertion, like walking or cognitive engagement.
Second, must-know communication strategies. Always utilize and model I statements to facilitate assertive communication. I feel frustrated when. It removes blame and sets clear boundaries.
And crucially, in the post-crisis phase after a restraint event, never, ever lecture, scold, or demand an apology from a remorseful patient. Shaming is non-therapeutic and will re-trigger the aggression cycle, reintegrate them calmly.
Third, must know emergency actions and the aggression cycle. You must match your intervention to the exact phase. In the triggering phase, use a calm, open approach and offer PRN oral meds.
In the escalation phase, when the frontal lobe is offline, shift immediately to a directive, firm approach. Order a timeout and initiate a show of force by having 4 to 6 staff members stand by to provide an external visual boundary of control.
Fourth, must know legal and ethical principles regarding crisis management. Physical restraints in seclusion rooms are always the absolute last resort, governed by the strict legal principle of the least restrictive environment.
They are only used when the patient poses an immediate, unmanageable physical danger to themselves or others, and all verbal de-escalation and chemical options have failed. If restraints are applied, you must have a minimum of 4 to 6 trained staff members present for the takedown, and you must obtain a provider's order immediately.
Fifth, must know pharmacology. For severe acute psychotic vegetation, the gold standard is the combination of haloperidol to block dopamine and lorazepam to enhance GABA.
But you must memorize the red flags. Watch for the benzodiazepine paradox, where Ativan causes disinhibition and increases violence in patients with personality or substance disorders.
And when giving Haldol, continuously monitor for extrapyramidal symptoms, specifically the painful muscle spasms of acute dystonia, and have the anticholinergic antidote, benztropine or cogentin, ready to reverse it.
If you master those 5 pillars, you possess the clinical framework to answer the most complex priority, safety, and delegation questions the board exams can throw at you. More importantly, you possess the knowledge required to actually save lives and de-escalate chaos on the floor.
The transition from a novice to an expert in psychiatric nursing is defined by the ability to anticipate rather than react. That synthesis is the blueprint for anticipation.
We are at the end of our deep dive today, but before we sign off, I want to leave you, the listener, with a final provocative thought. Something to process on your drive home or as you review your notes before your next shift. We have spent this entire hour, and we spend so much of our clinical energy meticulously assessing the patient.
We chart their neurochemistry, we map their trauma history, we study their cultural background, and we analyze their triggers.
But how often do we turn that high-powered clinical lens inward and assess our own triggers?
It is the ultimate question of the internal milieu. The nurse is the ultimate regulator of the psychiatric unit's environment. You are the thermostat that dictates the temperature of the ward. If you are running hot, the unit runs hot.
Exactly. You have to ask yourself, are your hidden, unexamined fears, your unspoken resentments toward hospital management, or the exhaustion and suppressed anger from a brutal commute subtly raising the baseline anxiety of your patients?
Remember, patients in psychiatric distress have broken filters. They are incredibly, hypersensitively attuned to nonverbal cues. They can feel when you are avoiding them out of fear. They can sense when you are rushing a conversation because you are frustrated.
Your own self-awareness, your emotional regulation, and your internal peace are just as critical a life-saving medical intervention as the Haldol locked in the Pyxis or the leather restraints secured to the wall.
Mastery of this field isn't about learning how to physically overpower or chemically subdue a patient. It is about mastering yourself to such a degree that your very presence can guide a terrified, dysregulated human being back to safety.
There is no higher calling in medicine. Thank you for joining us on this deep dive. Your dedication to dissecting and mastering these incredibly complex, heavy concepts is exactly what will make you a phenomenal, safe, and elite clinician. Keep studying, trust your judgment, stay safe out there, and we will catch you on the next deep dive.